interesting to hear. It's just how I got started in all this, really. I'm a registered nurse. Been a registered nurse for over 40 years. Was born and raised in the Chicago region. Always expected to live and die in the Chicago region. Never ever thought about moving away. But shortly into my nursing career, about 8 years in, I saw this little advertisement for a family nurse practitioner program at Indiana University. Now this was back in the 70s when it was obscure, okay? It was really not much long. In fact, I had a group of friends, nursing friends, and I was telling them what I was going to do about going into this pilot program. In fact, it was a pilot program for Indiana University to see if they wanted to bring the nurse practitioner program into the university. And I told my friends about it, and they all laughed. Why are you throwing away your nursing career? Nurses won't let you do what you want to do. Because you understand, I had been a hospital nurse some. At that point, I was actually a school nurse. But I had been in the hospital. Hospital nursing never worked for me. I didn't want to take care of patients at such a far along. I wanted to help promotion and disease prevention. And so that's where I was focused. And so I told them that. That's what I wanted to do. I wanted to be someone who would take care of patients at the beginning of the trajectory, not at the end, and try and undo years of, all these other things. And so they all laughed at me. They told me I was throwing my career away. It's interesting as you look back on the last 33 years. I've been a nurse practitioner now for 33 years. Finished the program at Indiana University, and because it had been a long, intensive program, took my family on vacation to the Smoky Mountains. Went down to Gatlinburg, beautiful area. My father was originally from the Tennessee area. He was one of those Tennesseans who went north during the Depression and worked in the steel mills and met and married my mom, a northerner, a Yankee, and raised his family in the Chicago region. And I married a man from Chicago and never expected to move away from there. So, but then went on vacation to the Smokies. Found that they needed a nurse practitioner in Crab Orchard, Tennessee. Little town of 1,000 people. Do not even have a stoplight in the town, okay? They have 2 stop signs on the Cumberland Plateau, just in the foothills of the Smokies. And so our family, my husband and 2 children, moved to Tennessee, and that's where I was for 20 years. Family nurse practitioner. Initially, the doc only came a half day a week, but anyhow, so that really grew. But after 20 years, I'd done a lot of work with women's health and went back. And I was a nurse practitioner before you had to have a master's, so it was time to go back and get my master's. I went to University of Tennessee in Knoxville for my women's health nurse practitioner. But anyhow, and it was in there that I met a patient that changed the trajectory of my life. Prior to that, I only expected to go back and get my master's and then go right back into clinical practice. It never, ever crossed my mind to get my doctorate, to do research or anything of that sort. But because I had done so much work with women's health and I was pursuing this women's health nurse practitioner, they put me in a high-risk OB area. And I had a young lady come in who was 25 years old, young, happy. The history taking was all just picture perfect, nothing wrong with it whatsoever. And so when I did the pelvic exam, when I went in to do the physical exam, everything was fine until I got to the pelvic exam. And when I started the pelvic exam, she went ballistic on me. She got hysterical, got so upset. And so, we stopped the exam, sort of explore what was going on. And she was having recovered memories of childhood sexual abuse. Which, really, it was a new area for me. I had really never explored that before. It happened to hit at a time I was in my nursing issues class, and I had to have a presentation much like this. And so I chose to, and you had to research it, things of that sort. I chose to do it on women with a history of childhood sexual abuse. And so I did that, and on the presentation, and we're sitting on the big conference table, there's 17 nurses, a couple professors and your colleagues, and I give my presentation, and afterwards, during the question and answer period, of those 17 nurses, 15 either had a personal story, a family member, or a very close friend. And that point that I would go on and get my doctorate and do women's health research in the area of health outcomes of women with a history of abuse. I mean, it was so clear at that time. And I had not even, I mean, it was a surprise to all of us because I had not even contemplated going on for my doctorate. So we packed up and moved to Atlanta, Georgia, and I went to Emory University. I received my doctorate there, and my doctoral work was all looking at health outcomes of women with a history of abuse. And in the process, I have to tell you that when I was finishing up at University of Tennessee, I met, my research instructor was Dr. Joanne Hall, who back in 1994 had written a seminal article about marginalization. In fact, we were in a class, it was finishing up the research class, and she had brought in a special speaker to talk about a research program. And at the end of it, she said something about marginalization, and we all sat there with these blank looks on our face. Had never heard the word before. And she said, "You have Dr. Joanne Hall sitting right there, and you don't know about marginalization?" Well, Dr. Hall and Dr. F.F. Melise from the university, she was from the University of California, San Francisco at that time, but anyhow, she's now at UPenn. They had written this sentinel article back in '94 about bringing marginalization into nursing science and looking at vulnerable populations. And when I learned about marginalization and how people are pushed away from the powerful decision-making center and pushed to the margins, and then the article broke down sort of like the sub-concepts of that, one of which is voice, and how when you lose your voice, you lose your power, and all these other things that go along. And I knew that when I went to Emory University, I would be doing my doctorate in marginalization, abuse, and health outcomes. And it's just, you know, at the time when I went to Emory, they had not really heard that much of marginalization, and they all sort of looked at me funny, like, you know, you can't do that kind of work. But I'm happy to say I had a most wonderful dissertation chair, Dr. Ora Strickland, who is now the Dean of Florida International University of College of Nursing. And I was so clinical that I really could not put it into the academic language and mindset, but she really mentored me through. And since that time, I've been, for the last 12 years, doing this type of research, looking at health outcomes, looking at marginality. In fact, in my doctoral work, I made a rudimentary marginality index and could sort of measure. You have to understand, in order to look at anything, you have to have a good measurement tool. There's nothing out there to measure marginalization, and so I felt like we needed one. And at my doctoral work, fortunately, these women that I had done this work with had all taken the MMPI, which is the Minnesota Multi-Personality Inventory, and from that, using those subscales, I was able to construct a marginality index. Now that started back, you know, during my doctoral work. And that started out with 95 questions. I have now distilled it down to 5 questions, and it's easy to take. I've worked with it. It's had good reliability. We're in the process of using it. I've used it with several. The reliability has run anywhere from 84 up to 96. And the closer you get to 100, the better off you are. So it's been a very reliable tool, and I've been real excited. So we won't get talking about that too much. I'm telling you, when I get started talking about my research, I sort of get off on a tangent. So we're here today to talk about sexual trauma and the health effects. So I want to talk more about that. But I'll be bringing it in. You have to understand, sexual trauma research. I'm sorry, is that? I know that's static. Is it really static?
I'm sorry. You want me to turn it off?
We could gather around. We could all come up to the front.
Do you want me to take it off, or?
Yeah. Just turn it off.
We can hear you fine up here.
Yeah. Okay. If you can't, just raise your hand and I'll speak up. But anyhow, yeah, keep in mind, sexual trauma research is relatively a new science. In fact, sexual trauma was always a very private subject that you really didn't talk about. Even back in the 90s, when I was thinking about doing this, when I was doing that first presentation, I went to one of the community leaders in our small town and said, you know, I had no idea that women with a history of sexual abuse had such impact on their lives. I said, we need to do something about it. His comment was, we don't talk about those things. And that's the problem. If you don't talk about it, it'll always be in the shadows. So, and another thing, these women are silenced so often. And, you know, I'll talk more about silencing also. But it's a relatively new science, baby science, I call it. In 1973 was the first time you could really find an article about childhood abuse, whether it be sexual or, at that time, it was sexual and physical. We now have more into emotional abuse, looking at how emotional abuse has quite an impact. Back then, it was really just, it's just things you could see, okay? And sexual and physical abuse is what it was. But a very sentinel article, and there was some real controversy with that. The first article on intimate partner violence, you know, intimate partner violence was a very private, personal thing. Family, you never talked about some husband beating up his wife or what. You know, that was his right. If they didn't get along, he could do those kind of things. But anyhow, so that was our first article in '78. And then in '81, battering in pregnancy, which we now know is quite prevalent, but it was relatively new back then. So the scope of the problem, in 1993, the CDC actually identified violence as the #1 health problem in America. And violence in the form of sexual abuse was really a significant public health. As a result of that, and it is for females of all ages, from childhood on up, from infancy all the way up to elderly, okay? But as a result of now the CDC recognizing that, the legislature passed the Violence Against Women Act in 1994. And this is what gave the funding to now be able to do research in this area. So when you stop to think about it, the research really, you saw a little bit back in the 70s, minimal back in the 80s, but the research really started in the 90s and going forward. So stop and think how young that is. That's not a very old science at all. This Violence Against Women Act has to be reauthorized every 5 years. In fact, if you were watching the news last week, there's a big controversy. It's been extremely beneficial for women, beneficial for society, really, when you stop and think of the impact. But now I know different people want to have different people have input, and they try to add more things. But initially, it was just phenomenal the way it opened up the funding and the research that we could really find out what was going on. Initially, in the first 5 years, most of the funds went to Department of Justice for educating police officers, the court, people that of that mindset. In the second reauthorization in 2000 is when they realized that the courts are getting it at the end, but really healthcare professionals see these women early on, and this is where they needed to do the education. And so a lot of funding was given to healthcare personnel after that. It is up for reauthorization, and you should be hearing more. Keep your ears open. You'll be hearing more about this. Keep in mind that one of the things in the early research, we really don't know the full scope of trauma, sexual trauma, mainly because we have no standardized definitions. And so the CDC has more or less tried to standardize the definitions of this intimate partner violence. And you have to understand, I'll be going back and forth between sexual trauma and intimate partner violence because most of the research has been done under the umbrella of intimate partner violence. But before it could be, but they've given this definition: physical, sexual, or psychological harm by a current or former partner or spouse. It can occur heterosexual or homosexual. It can be, it doesn't require that sexual intimacy. It used to be, some did, some didn't, but it doesn't have to. It's just, it can vary in its frequency, its severity, and it occurs on a continuum. These are the 4 main types: physical, sexual, threats, and then psychological or emotional. There's also some added to that. There's also financial. Financial types of violent or intimate partner violence, but this is the the most common. These are the four most common. Scope of the problem. And we say the scope of the problem, but we think we've really just looked at the tip of the iceberg because, you know, what's being reported is not always what's going on. You know that very true of it from the people who, you know, you all shared and you've worked in this field. You know that we're just scratching the surface. We're just really realizing that there's a lot more out there. But anyhow, 1 in 4 women in the U.S. have reported being violently attacked by a husband or boyfriend. I mean, stop and think. That's pretty prevalent, 25%. 1 in 5 women indicate that they've been sexually assaulted in college. I'm really amazed at this. When I speak about this, I just remember one person sharing with me how she was, you know, in college and her girlfriend and her best friend and her boyfriend connived and set up a situation so that he could rape her because she shouldn't graduate from college being a virgin. And you're thinking, what a mindset. I mean, what a mindset we've got. But anyhow, 1 in 5 women, it's a very prevalent. And if we are just scratching the surface, that might be 1 in 3 or 1 in 4. So it might be even more prevalent than that. A large study, national study, revealed that 1 in 9 teen girls report being forced to have sex. I mean, these are teenagers, 12 to 17. Intimate partner violence results in over 2,000 deaths a year. Of those, 70% is female. When I talk today, we're going to talk mostly about women's health because I'm a women's health researcher. It doesn't mean that it's not in the male realm also. It's prevalent there also, but we're 3 times worse in females than it is in males. So that's, and of course, being a women's health researcher, that's where my focus. But I don't want to negate that. There definitely is abuse. It's really not gender specific. It's just that it's much more prevalent in the female population. The cost of the problem, we estimate, and we estimate by what the figures we know. So if these are the figures we know, can you imagine what the figures are from what we don't know? But it exceeds over $5 billion annually. The largest component of this is health care. There's a lot that goes into the health care of these women. Over $4 billion for direct medical and mental health assistance, lost productivity from paid work, and from homicide that occurs as to the lost lifetime earnings. There was a phenomenal study done back in the late 90s that was done in 11 cities about femicide, looking at how women are killed by their intimate partner. And Houston was one of the cities. In fact, my colleague, Dr. Judith McFarland, was the lead PI for the Houston. It was originated out of Johns Hopkins with Dr. Jacqueline Campbell, and Dr. McFarland is now, you know, was the Houston PI. And I have to say, I'm so proud of the work they did, because the work that they did with that was actually used in a Supreme Court ruling, 2010. Supreme Court Judge Ginsburg used that work to rule that batterers cannot own a firearm, because that is the highest risk for a woman being killed, is if their partner, if they've had a history of being a batterer, they cannot own a firearm. But anyhow, again, I get sidetracked. But this is nearly $1 billion in lifetime earnings lost by those who've been killed by their partners. Annually, it results in about 2 million injuries. Some of those are quite horrendous injuries and it uses considerable medical attention. And they estimate that annually we lose a total of nearly 8 million days of paid work. Stop and think about that. That's the equivalent to 32,000 full-time jobs, or 5 million days of household productivity because of this trauma that these women have gone through. The greatest risk for sexual violence is being female. We know that. Just being female puts you at high risk for violence. There's other things, and this was from, a lot of this came from that research, the femicide study, is that lower educational level, if they were exposed to child maltreatment, if they've witnessed parental violence. I have to tell you also right now, with Dr. Judith McFarland, she and I are on a research study right now that we're following, that's been funded, underwritten by the Houston Endowment, where we're following 300 women and one child. We're following them for those 3 years and looking at witnessing parental violence and what the health impact and implications are. But anyhow, excessive alcohol use, or not only alcohol, but any kind of drugs. Attitudes accepting of violence. You'd be surprised, so many, we just stand in shock about the violence, but you'd be surprised how accepting many cultures are of violence. That's an accepted thing. I go back and think about, in fact, I was watching one of my favorite movies. I love to watch John Wayne in The Quiet Man. It's set in Ireland, and my husband's family's from Ireland, and I have a little bit of Irish in me. But it was always one of my favorites, and it's amazing how after I've been in this research, I now watch that. And there's one scene where when he's dragging his wife across the field, and this little lady comes up and says, "Here's a stick to beat your lovely wife with." And I'm thinking, it's so accepting, you beat your lovely wife with. It's just, I had never noticed that phrase in that movie before. But there's cultures that's very accepting of violence, and that makes you at higher risk for enduring that violence. Past history of violence, we know that once abused, especially if abused before the age of 12, it puts you at much higher risk for re-victimization, marital discord, dissatisfaction, male sexual entitlement, and then weak sanctions in the law for violence. And we see this so often, that if a woman wants to pursue something about rape or something of that sort, she now becomes she's re-victimized by the justice system. That she is, how did she perpetrate it, different things. But anyhow, so it has a lot to do with how the justice system views the sexual violence also. An interesting book was The Global Burden of Disease that the World Health Organization uses, and it was interesting when they listed the top 10 diseases for disability in the world. 5 of those are diseases you commonly see in victims of abuse. And depression, very common, alcohol abuse, bipolar mood disorder, schizophrenia, and obsessive compulsive disorder. World Health Organization actually says that depression is the leading cause of years lost due to disability. So it's not just a local problem. This is a worldwide problem. And it's interesting that depression is at least 50% higher for females than it is for males. So why study abuse and health outcomes? A history of abuse, especially abuse before the age of 12, is associated with stress-related mood alterations. Dr. Charles Nemiroff and Christine Heim out of Emory University has done quite a bit of work looking at, and this is the interesting thing, is that it's not all in their head. There are physiological changes to account for why there's an increase in that anxiety and depression that they're experiencing. Because the history of childhood sexual abuse impairs the physiological pathways, this was their conclusion, causing long-term altered stress response via the alteration in the regulation of the hypothalamus pituitary adrenal triad there, which contributes to long-term mood disorders. So after the abuse, it's just not confined to that one area. There's long-term effects from that. History of childhood abuse is significantly associated with repeated abuse and multiple health outcomes. It's found, actually, childhood sexual abuse has been found to be the most powerful predictor of psychopathology, such as anxiety and depression. History of childhood abuse abuse has also been highly correlated not only with depression and anxiety, but also with substance abuse, PTSD, suicide, and multi-personality disorder. So, I mean, there's a lot that goes on with this. This one study by Dr. McCauley is she does a lot of work in this area, but women reporting abuse in childhood had higher scores for anxiety and depression than women who reported adult abuse, okay? The physical symptoms were more common. They were 4 times more likely to be abusing drugs and alcohol, and 4 times more likely to attempt suicide compared with women who had never experienced abuse. So, I mean, it's quite an intense problem. For young women, adolescents, between 16 and 24 is the highest per capita rate of interpersonal violence. It's also the highest rate for rape during those years. 1 in 3, I thought this was such a sad, when you think about our high schools, 1 in 3 high school students have been or will be involved in an abusive relationship. And what's interesting is most do not disclose it. Okay? Later on, I'll talk to you about self-silencing, how girls and women self-silence themselves to maintain relationships, and this is what we really see very prevalent in high school. You know, they're very protective of their boyfriends in different ways. But anyhow, adolescent girls reporting abuse also report higher rates of pregnancy, higher rates of illicit drug use, binge dieting, you know, your bulimia and your anorexia, and suicide attempts. The National Crime Victimization Survey, this was a sentinel survey that the CDC underwrote. They revealed that most rapes occur, this is such a sad statistic, most rapes occur before the age of 24. 29% of those before the age of 11. I was amazed with this. When I first got into this work, you know, you think you know people. You think you know them well. I had a friend, we'd been close friends. We had talked about everything you could think of. We'd been close friends for 15 years. And once I started working in this, one day she said something about, I never told you that I was raped by my grandfather when I was 5 years old. I mean, and it just completely takes you by surprise. And you say, what did your family say when they found out? Now, this woman was in her early 50s, and she said, I've never told you. You're the first person I've told. She said, we would not ever talk about something like that. I said, why wouldn't you do that? Well, I just knew that if I did, my mom and dad would be so angry. You know? So, I mean, 29% of these are raped before the age of 11. You know, we think that it's not out there. We think that we're not being affected or impacted, but you'd be surprised. People don't talk about things until something will trigger, and they'll bring it up. But anyhow, and this woman had multiple medical problems, and I am never once connecting that it might be related to that, that trauma long ago.
But how does a 5-year-old get the sense that they would be angry if they found this out?
How do they get that sense?
Yeah.
You don't know the dynamics in the family.
Yeah.
You don't know if it's a functional versus dysfunctional. You don't know how they communicate. You know, communication is so important. And communication, it's hard to judge what would be done back then versus what's being done now, because we're much more open now than we are.
But I mean, how you get that sense is based on the patterns of the family.
I mean, at that developmental stage, isn't that a likely interpretation? It's so early in life.
It could be developmental.
Well, they could be told that by the perpetrator. You know, if you tell anybody.
Well, that's very true. That's very true. You know, they're threatened in many ways. You know, you tell anyone, and it'll break up the family. You know, mom and dad will never. You know, you'll never be able to allow to do anything again. They'll never let you on your side. They can put that fear in them in many ways. I don't know. We never explored that more. I did get her connected with some counseling, but and that happened just as I was moving away from that area. So I just was not able to follow up. But that's a good question. How does a 5-year-old? A more recent study revealed that 60% of females victims were first raped before age 18. Again, that cutoff below 25% of them. The effects of sexual abuse has a lot of other implications also. Besides, it has unintended pregnancies, has multiple gynecological problems. It has spontaneous and induced abortions. How many women have been raped and they do not feel they can carry that pregnancy. There's an increase in sexually transmitted diseases, including HIV. Violence in pregnancy, and we know at least 20% of pregnancies have some violence in it. It increases the possibility of miscarriage, stillbirth, preterm delivery, and low birth weight. There's a lot of research going on in the pregnancy aspect of this, because we're realizing that from the time of conception onward, what that fetus and what those young children are exposed to, it has long-lasting effects. But anyhow, talking about long-term effects, this was a large study, over 3,000 women insured. It was through an HMO that they were able to do this, where they were questioned about their abuse history, they were questioned about their physical, mental, social health. Of that, 34% of them had sexual interpartner violence. Okay, 34% of them. Again, we're getting that 1 in 3, but only 5% within the last year. But when they look at the outcomes and the health outcomes of these women, they definitely had some long-term outcomes. And if they've only, nothing's happened in the last year, only 5% of them had something happen. It was the effects of the long term. These women had worse overall health. Depression was 3 times more prevalent among the sexually abused women. Women who were sexually abused were twice as likely to report fair or poor health, had much more symptoms, and they were very lacking trust in the individuals, which, they've had their trust betrayed. So why should they trust individuals in the community? The National Violence Against Women Survey, 25% of the women have been raped or physically assaulted by an intimate partner. And from that, they've estimated that there's almost 5 million incidents of intimate partner abuse annually. And this is an older study, so we're not even sure. Look in the newspaper, on the news every night. You're seeing things. Baylor has done a wonderful study back, a 10-year study. This was a study that they initially were only going to look at women's sexuality, if women who were disabled and looking at their sexuality. But as they got closer to getting ready to start this, they had a consultant who said, you really need to put some questions in there about abuse. And that had not crossed their mind before that. So they put some in there. And it was amazing that was the major thing that came out of it. They had a very high rate of abuse emerged as one of the most prominent findings of their study. 62% of their participants had experienced some type of abuse in their life. 62%, we're talking. They took this finding as a mandate, and they've done some wonderful work. They've got some wonderful work of looking at women with intimate partner violence and disabilities. Stop and think, when a woman is disabled and really that dependent on their caretaker, are they not much more accepting of whatever happens? If they get angry, if they throw things, whatever, they're much more accepting of that. In research, we always say, so what? Why? So what? So why are you doing this? Women are twice as likely to report anxiety and depression. They're 3 times more likely to be sexually abused than men. And I look at can these disparities be explained by gender communication, maybe? I'll be getting into more about marginality and self-silencing, and I think it has a lot to do with women's lack of voice. This was my doctoral work. It was called Marginality, Abuse, and Adverse Health Outcomes. It was a community sample. Actually, it was a retrospective study of 568 women. in reproductive age, because initially it was a PMS study. They were looking at neurometric indices so that they could put PMS in categories. They had non-dysphoric, which means if it's non-dysphoric, it means it's more physical symptoms versus emotional symptoms. And they were able to classify into 7 different types of PMS. Well, I should say different types. No PMS is the largest one, okay? The largest among women were in the no PMS. But in that, we also saw different parts. In that, again, I told you that I had put together a rudimentary measurement of marginality. It was interesting that this tool correlated with abuse, and correlated with the adverse health outcomes, exactly how I would have expected it to work in the theoretical framework. And so marginality significantly correlated with all forms of abuse, and abuse in all age categories. In this, this was a wonderful study. It was interesting in that they had asked 100 questions about abuse in childhood from 12 years and under, in adolescents from 13 to 19, and then from 20 onward for adult. And so I was able to look at whether or not they had sexual abuse or physical abuse, you know, who was a perpetrator, and whether or not they had followed up with mental health. It was interesting. They had 100 questions of that. And so I was able to, you know, put them in those different categories and then look at the different types of abuse also. Sexual abuse significantly predicted marginality. So when someone's sexually abused, it sort of pushes them farther away from the center of the decision making. It sort of puts them on the margins. It puts them where they have less voice, less involvement, less power. Okay? They almost get more secretive in the way they deal with life. You know, if you look at women who have a history of abuse, many times you won't know it for years and years and years because they've been very secretive about it. You know, it's a part of their self-protection. Marginality was a significant predictor for abuse before the age of 12 also. Anxiety and depression significantly correlated with all forms of abuse and abuse in all categories. And so through that, I was able to say whether or not they had childhood sexual abuse, adolescent, adult. I could look at when was it initiated, when were they first, and that's where I looked at women, women who had a history before the age of 12. And then I also did a lifetime projection. If I put all of that together, how much abuse. But it was we couldn't really do dose related because it was not a large, the way it was measured was not, and we weren't able to do dose related. So, you know, the question is why study marginality, abuse, and health outcomes? It's because women in violent relationships have been found to be restricted in the way they gain access to services, how they take part in public life, how they receive emotional support from friends and relatives. In addition to Baylor that does work with disabled, Canada that has a wonderful network also that works with the disabled women's network. And they surveyed 245 women with disabilities. 40% of theirs, 62% of Baylor's, but 40% had been abused. 20% had been raped. But what was interesting in that study is less than half ever reported what happened to them. And that, again, goes back to the fact to me that they've been silenced. Another study that I had done was the history of abuse and its relationship with the age of abuse. This was another piece of that doctoral work. This is a busy slide. It has a lot of text on it. The most important thing to take away is that the physical, sexual, and total abuse significantly predicted anxiety, depression, and how severe the PMS would be. Okay, and that anxiety and depression had significant positive correlations with abuse. Okay, this last part where it talks about only 2%. I have a better picture for you. This is a picture that shows you it better. Okay, when we looked at when I looked at this, I should say, but. The group that had no PMS, only 2% of that sample, that subsample, were abused under the age of 12. Okay, 1% was abused over the age of 12. If we looked at the PMS groups that only had physical symptoms, you know, bloating, let's see, weight gain, things of that sort. So physically there was things. They had 2% abused under the age of 12, 2% or 3% over the age of 12. But look at the emotional symptoms. If they had the type of emotional symptoms, anxiety, depression, 20% of that group had a history of abuse, and 10%, or I'm sorry, 20% were abused under the age of 12, and 10% were abused over the age of 12. I mean, those are startling. That was one of the startling statistics that came out of this research. I also sort of teased out, instead of the 568, this PMS study was actually a 3-phase. And so my doctoral work was done with phase 1, where we had 568 people, women, and they followed them and did menstrual histories with them. They also did a battery of tests. They did anger, they looked at the Spielberger anger, they looked at anxiety, depression, they did cortisol levels, they did a lot of physiological parameters also. But one of the parts I looked at was looking at anger and its relationship to PMS. And of course, anger, if anyone who knows a woman premenstrually, you see some anger there, okay, some more than others. But stop and think, you have to understand, when you look at a woman's menstrual cycle, it's really divided into 2 parts. It's the first part of their cycle is what's called the follicular stage, and that's where the egg is getting ready to be burst out, what's called ovulation, okay? And then after ovulation, you have the luteal phase, okay? And that's where the body's getting ready for the implantation. But anyhow, so these tests, the Spielberger and all these instruments were given in both the follicular stage and the luteal stage to see if there was a difference, okay? And only in the dysphoric groups, so that's the emotional, the ones that had emotional symptoms, was it statistically set. This just, again, pictures show you a little better. The dark green is the no PMS group, the light green is the physical symptom group, and then there's a thing called dysphoric PMS, which is the premenstrual syndrome, but then there's a premenstrual magnification also. Then these women have that very severe emotional symptoms. But anyhow, both of those dysphoric or the emotional symptoms were statistically different. We saw a great deal more women in that group with abuse than we had expected. I also looked at cortisol. And cortisol is a stress, it's involved when we're talking about stress mediating a factor. So I looked at the same group, and these women, you know, this was not 568, this was 244. But anyhow, we looked at the cortisol levels, and cortisol is how you mediate stress, how you deal with stress. Cortisol levels decrease from the follicular to the luteal, okay? And when the lower the cortisol levels, the less you're able to deal with stress, okay? But an abuse was significantly associated with all the PMS groups. This is just trying to show you the difference. Let's see. Does this have a pointer on it?
Yes, it
if you look
does.
at this, sexual
Right.
abuse, but and you understand, and before it had this
You can point.
center one. Oh, there it is. Okay.
A little bit.
And so I was able to look at cortisol levels in the 3 sections: the childhood, adolescent, and adult. Before that, they had only looked at the cortisol levels as the whole group. And so all they had was looking at women, all of the women, and it's like 53. That's pretty strong. Didn't look bad. But when you tease out the women who had sexual abuse versus the women who had no sexual abuse, look at this discrepancy. Look at 20 for women who had a history of sexual abuse, and 58 if they had no sexual abuse. Okay? All right. So a big discrepancy. And when you go from follicular to luteal phase, we expect it to go down because that's part of the menstrual cycle. But the women who have sexual abuse, they can't go very low because there's what's called the floor effects. They're already low. They already can't. They're already having difficulty dealing with the stress. Does that make sense? Does that? Can you? I mean, I get into statistics, so those numbers mean something to me, but I'm not sure. Adolescents, we see the same type of things in adult, but look, it's definitely the childhood sexual abuse is where you have the biggest discrepancy. So relationship, if we're looking at the relationship of cortisol to PMS with women who have that history of abuse, it increases their vulnerability to the altered cortisol, which is that stress-mediating substance. It decreased more in the luteal phase in the group with no abuse. And again, I talk about that floor effect. So these physiological menstrual patterns and abuse history have an impact on women's health. And as providers, we need to keep that in mind. When we're seeing these women, are they in their follicular stage versus their luteal stage? How often do you ask, when was your last, when you're dealing with a woman in clinically, how often do you ask that? Because it may make a big difference if they have a history of abuse. The other thing I looked at was PTSD scores, post-traumatic stress disorder. Looked at that same 244 women. Marginality, again, I was looking at that. This is the first instrument I had. I'm looking at marginality, anxiety, depression, and PTSD scores. There was positive correlations, very significant positive correlations. Most of my correlations were positive to the 0.01, which is, we usually use the marker or the cutoff of 0.05. So the fact that I could do it 0.01 and some even to 0.001. So it was quite significant. There was a significant difference between the mean scores of PTSD, the anxiety, depression, between those who had had the abuse and not. And what was interesting, and the next one will show you, the PTSD scores increased as marginality increased. Look at the difference. For women who had they scored 0 or 1, their mean score was 9. And keep in mind that the higher the number, the more marginalized, in theory, okay? Because this was the first time I've used this instrument, so I was still developing this instrument. But as the number raises, and 7 was the highest, look at the difference between 9 and 30, and how it just, the more marginality, the higher the PTSD, okay? And keep in mind, sexual abuse in my earlier had significantly predicted marginality. So if you make that, following that along the way, the sexual abuse, it stands to reason that the PTSD scores would raise for them also. Relation of abuse, and then this led me to the silencing part. You have to understand, marginality is very important to me. And there's 7 sub-concepts, this marginality. There's intermediacy, I could name them all. Intermediacy, differentiation, power, secrecy. But anyhow, what really stood out to me, that the intermediacy and the differentiation is the boundaries people have, and then how they maintain those boundaries. But then, of course, voice, how are they able to stand up for themselves? Power, whether or not they have power within society. Secrecy, and then there's some hypersensitivity also there. But anyhow, so the part that really came out to me was the silencing, how women self-silence themselves in order to maintain relationships. And by self-silencing themselves, then they're at higher risk for abuse. In this, this is further work, that I've done. I did it in Georgia. I had a sample in Georgia as a pilot study, and then when I came here, I finished up with a larger sample. And of this group, and this is a community group. These are women in the community, did face-to-face. They were filling out my questionnaires with the marginality index and anxiety, depression, things like that. Of this group, 51% reported abuse, much higher than the 1 in 3 that we've been seeing. 35% were childhood abuse, 11% adolescent, 32% adult. The type of abuse, what we see, 27% for sexual, So that's what we've been seeing. But the emotional, we're seeing more and more work looking at the emotional, because we know emotional. Some people say, just hit me and get it over with, but don't keep putting me down and putting me down. So the emotional, we're finding out the emotional has quite long-term effects, okay? But in this study, all types of abuse in all categories. Types of abuse, again, I was looking at the physical, sexual, the emotional, and the all categories, that's the childhood, adolescence, and adult. Marginality, self-silencing, and family function were the significantly positively correlated outcome. And I was looking at anxiety, depression, and then I have a list of 66 different health outcomes that they will check off. And so there was significance between the health outcomes also. So this was 244 women. It was a community sample. The mean age was 49 years old. Caucasians, but anyhow, there was a significant relationship among the sexual abuse, the marginality, and that adverse health outcomes of anxiety, depression, and then that list of health outcomes that I had. So it really brings home how the health impact of abuse has, this abuse has long-term consequences. So why do I study abuse and silencing? We'll keep going on and on. Why do I study this? In this randomized, Golding and Taylor has done a lot of work with this. And this was part of looking at PMS also, because they were looking at a clinical sample of severe PMS. Now, keep in mind, 90% of women have PMS, but only 5 to maybe 10% have the very severe debilitating PMS. And that's what they were looking at, is these women that have this severe debilitating PMS. 95% of those women reported having at least one attempted or completed sexual abuse event. I mean, that was a staggering statistic for me. 81% reported complete penetration against their will. Okay? But the thing that jumped out at me about the self-silencing, 83% had never disclosed that abuse to a health practitioner prior to this time. I mean, talk about being silenced. That really brought it home to me. So my mantra, I think of voice as the essence of marginalization, because without voice, one's power is decreased. Without power, one's choices are limited. Without choices, one's behavior is restricted. And choices of behavior impacts our health. So I believe that in the shadow of abuse, women are silenced. And that my goal for women with a history of abuse is that with voice, their power may be increased. With power, more choices may be available to them. And with more choices, their behavior may be positively impacted to make better health decisions regarding their health. And so I leave you with one, this is just sort of the end of my presentation. I was on the Cumberland Plateau for 20 years up in rural Tennessee. Okay, Dr. May Wharton was what they call Dr. Woman of the Cumberland. She came to the Cumberlands in the 20s. She really, you have to understand, the Cumberland Mountains, there's a 2,000-foot escarpment to get up to that. And back before we had interstates, that area was extremely isolated. And so Dr. Wharton and her husband came to the mountain to work in the academy that had been put there. This is before public education, and they wanted to educate the mountain children. She just came to be a teacher with her husband, and she was a medical doctor. But then 3 years into it, he died, and by then they had adopted her as their medical provider also, because after she had finished teaching during the day, someone would come with a donkey or a horse and say, "Can you come with me out?" 5 miles out on the horse, and they have to go out across the creeks and whatever, late at night, and she'd go out and take care of the family. So after her husband died, the community came to her and asked her to stay and be their medical provider. And she really is credited with bringing good medical care to the mountain. But anyhow, in her autobiography, this is one of her quotes: "What a blessing it is to be able to give stricken people the help they need to solve their own problems. It is our duty to help the weak, but it is truly our pleasure to give a helping hand to the struggling fighter." And so my thought is that patients with a history of abuse are struggling fighters. And through my research, I want to give that helping hand. So that's it. Open to questions, and I'll do my best, and if I can't, you can leave your email, and I'll try to get the answers to you.
In the PMS, severe PMS group, was there any connection with that and endometriosis, or
I
didn't look at that?
See, I didn't look at that. Actually, endometriosis was one of our health outcomes we had on that list of 66 health outcomes.
Oh, okay.
Probably could go back there and look, but
I'll leave it in my email.
endometriosis is very common, very common. Other question?
I have a really
Yes,
broad
sir.
question. What would you say is like the connection between this marginality and spirituality? I mean, it seems kind of obvious maybe, but I mean, it's something that you've been working on. So.
What do I've not explored that, but since I've been here, I'm actually on the board of trustees here at the Institute, so I'm learning more and more about the Institute, and we have a wonderful scholar in residence, Dr. Ken Parkman, and his work with spirituality, and I'm hoping within the next year to work with him. And I've not really explored that aspect of it.
Now, you mentioned it's a 5-item questionnaire for marginality.
Yes.
It's
What
validated.
It's been valid, yeah. You understand, and actually the publication, I've sent the manuscript off. I initially started this, and I've actually done presentations. I have an actual presentation that tells you the whole development of this and the psychometric work. And what I did initially, with the Marginality Index, I looked at the MMPI, and you understand, the MMPI is used for both clinical and non-clinical. So they have clinical subscale, or scales, but one of the things is we didn't want to pathologize our, women with a history of abuse, so we did not take any of the clinical scales. We looked only at the supplementary and content scales, and matched the 7 sub-concepts with a supplementary or content scale, and that's how. And then we took those measures and had the cutoff scores. That was 95 questions from that. From that, I distilled that down to 70, and did the first 2, that relationship, the first 2 of a pilot study and then a larger one of the 244 women, and looked at the validity of that 70. That validity was 96, or I'm sorry, internal consistency was 96. And again, the higher you get closer to 100, the better it is. On both the community sample of 50 women and then the community sample of 244. The 50 women in Georgia and the 244 here in the Houston area that I did. So that was that. But you have to understand, that was 70 questions, and it was very labor intensive. A lot of, research, people doing research, or participants are not real keen on taking time for 70 questions. And with Dr. McFarland was getting ready to do this new study that we're following these 300 women for these 3 years. She said, Anne, you've got to distill this down. Well, part of that last study of 244 is I did exploratory factor analysis, was able to distill that down even farther, and from that I took the highest correlations of those questions and took those 5 highest correlations and made this 5-item, okay? So now we're following these 300 women. Well, we're doing, we recruited 150 women from, these are 150 women who have initial domestic violence, intimate partner violence, and 150 of them have been recruited from, they went to the DA's office to get a protection order. So they went the community way. These are community women. And then 150 women who have chosen at that initial abuse to go into a shelter. And we're following those 300 women, 150 sheltered women, 150 community women. And we're following them every 4 months with a battery of interviews and instruments. And so my instrument is one of them. On the baseline data, which is all we have at this point, the internal consistency is 84. So it's still, anything over 70 is considered strong enough to use. So I mean, it's not the 96 that I had, but it's still a quite reliable tool. So we're still doing psychometric testing of that. So I can tell you more. In fact, I hope within the year have that manuscript out easily accessible if you need to find out more about it. But anyhow, and I have to tell you that it's interesting with this tool. It just sort of, it's amazing how it's a snowball going downhill. And if you listen to the news, you hear marginalization more and more. I don't know if you've heard it, but I'll turn the radio on and they'll talk about so-and-so, this group is marginalized. And so it's really has come of its time. Back when I was starting it, no one understood what marginalization was. But anyhow, it's as a result of this, the tool has now been translated. We needed it in Spanish because a large portion of I think 35% of our group is Hispanic. So we've had it translated and back translated. And so we have it, again, 84 with the Spanish translation. I'm also doing research with a researcher in the University of San Diego and the Georgia Southern University that we're developing a model to be used globally. So the tool has been translated in Ukrainian, Russian, French Creole for use in Haiti, and then we're in the process of Japanese. So it's been exciting to see how it's grown, and it's being used in the group. Oh, and Filipino, and in the Filipino group, that was just we did a pilot study of Filipino, English, and Ukrainian. Unfortunately, Ukrainian we didn't get a large enough sample to really get a good internal consistency, but it was 81 with the Filipino group, 84 with the English group. So we're still getting good reliability. And I know it was so hard. They said you cannot have 70 questions. You've got to distill it down in something. So yes.
I know this probably wasn't your study, but from your reading and experience, is it true that the woman who has a lot of self-respect is less likely, in other words, one who has less self-respect is more vulnerable? Would that be a true fact?
Well, I don't know. For measuring self-respect, I know in self-efficacy, the stronger self-concept you are,
there you go.
The stronger. It's sort of a protective measure. It is more of a protective measure, but it's not completely protective.
Right.
I mean, what's interesting when you look at the abuse issues, abuse is much higher in what we expected in the lower poverty type thing, but it's also even more than in the low poverty is it extremely rich.
Right.
You would think women in that area might have more self-confidence, but in the extremely rich, abuse is quite prevalent.
Especially economic, women who have no money of their own. You can go in resale shops and find a lot of things for other reasons, but often with tags still on them because that's one way they have learned to get cash.
They're able to buy clothes and things
Right.
like that, and then they can resell them.
Right, and answer to Dr. Patrick Carnes, that's affiliated with the Meadows in Wickenburg, he's done a lot with spirituality and sexual abuse. Also, Drs. Townsend and Cloud, with their boundaries, got in to some of these issues also. And I know a number of females who have been abused by clergy, and that's of all spiritual, religious backgrounds. So, and then the concept for Christianity, when the abuse has been by a male, has been very prevalent because they have a hard concept with God as a male image. Also with males who have been abused, having that concept of a male God. So, and that's kind of a combination of nursing and my own spiritual experience and study. But one of the things I frequently see is lack of self-care for physical and being non-compliant with treatment programs. So, and distrust of the medical profession, often because it's done, quote, in private, which is where people were sexually abused in a one-to-one isolated position.
Well, it goes back with the trust issue.
Trust
also.
issues,
The
that's
trust.
right.
It takes a while. You just can't. And you have to understand, our healthcare system is changing. You know, you used to have the family provider,
Right.
and they knew the family all the way
Yeah,
through,
right.
and you had trust in that person. You knew you could go to whatever. But we're into, you know, walk-in clinics, retail clinics. Things. You never see the same person twice,
You
and
can
it takes
fragment
time to
and keep
build that
secrets,
rapport
yes.
and build that trust. And so you're not seeing that as much, and it makes it much more difficult before they will ever feel like they can trust it. I know an instance of one where this woman came in, and of course now in our complete physical history, or complete histories we take, we always include a sexual history and an abuse history. At least I do, and I really promote that. I'm the director of the Family Nurse Practitioner Program at Texas Women's University here in Houston, and that I'm very adamant with my students that they're going to know about how important this aspect is, and that they need to ask those questions. They ask them every time. I remember going out, and this woman, this student said, she came out of this seeing this OB patient, and I said, "Did you ask her about abuse?" Oh no, she's well dressed, and she doesn't look like there's any problem. And I said, "You can go back in there and ask her the question." So we walked back in, and she said, Dr. Koci, her focus is abuse, and have you had any problems with abuse? Well, this woman was sitting there, and her little 3-year-old was in front of her, and she puts her hands over her ears, over her little 3-year-old's ears, and says, "Yes, and I need to talk to you." Had she not asked that question, she would have missed that. But to get back to what I said, I remember this one where, the first year you're doing this annual well woman exam, and you ask the questions. Have you had, any, oh no, nothing. Next year comes back,
Right.
same thing. No. Third year, well, yes. And it's been going on, and how long it's been going on. Well, why didn't you say it earlier? Well, the first year I didn't know if I could trust you. The second year, after I left, I really would have liked to, and by the third year, she built up the rapport and the trust. So it takes a while to build that trust. So, anyhow. Any other questions? Yes, sir.
What about eating disorders?
Well, they're definitely seeing a strong correlation between eating disorders and abuse. And not necessarily the sexual abuse. I mean, the sexual abuse may be in there, especially emotional abuse has been very strong. I didn't bring any studies on that, though, but we have actually someone here who works with bulimia and anorexia, but
Yeah,
have you seen it in your
A
practice?
small part of my practice is doing women with bulimia, anorexia, nervosa. But also, I think some of my people with compulsive eating and binge eating, I'm suspecting that there's some history of sexual abuse or emotional abuse there, but I'm a little bit nervous about when I should jump in and do that, since I am a dietitian, I'm not a mental health professional.
Yes, but keep in mind, as a dietitian, you're not a health professional who will treat diabetes, but you still ask questions about whether or not they have any symptoms of diabetes or whatever, and your goal is not to treat them. Your goal is to identify the problem and then move them on to a resource.
Yeah.
So I think many of us initially didn't want to ask the questions because we feel like that's not our area. But, the opportunity's there, every opportunity. And I tell my students, you ask it every time they come in because life changes on a daily basis.
People will tell whoever they relate with and trust. I have seen patients talk with housekeepers or somebody else that they saw on a regular basis. They had a little more time cleaning their room when the other staff's always busy, in and out. So
It's that relational. The relational. It's a relational.
It's a relational
Right.
thing. So you might be the person for someone.
Yeah, and strangely enough, I'm a dietitian, which took me a long time to get the master's degree. Personal trainer, you don't need tons of training for. But there's a lot of intimacy in that relationship. You're working an hour twice a week with somebody,
Right.
and they share a whole lot.
Absolutely.
Yeah. But I thought it was interesting, you with the little girl and her putting her hands over the ears. That's
Oh, yes,
when the
she did.
silencing message begins.
Yeah,
The 5-year-old has in place.
Absolutely.
And
Absolutely. She can't let her know. And don't you think that child sees it on a daily basis?
Yes.
in that
Right,
home?
right.
She sees it, but she didn't want her to know that she was going to say anything. But anyhow, so yes, the silencing
Messages
aspect.
don't say anything.
Yes,
Mhm.
absolutely. Absolutely. That's silencing. Once you get into marginality and learn about that, you're going to see it everywhere you look, and you're going to realize how often people silence themselves. I mean, just like that one thing.
I watched something last night on the sex trade, in Houston, and it was that very same thing, because there are a lot of here illegally, and they're afraid, and particularly, and a lot of the people who aren't here, or they've been in governments that were very oppressive, and you didn't trust the police, or...
Absolutely. Let me tell you
Right.
just one, when this group were doing the baseline data, and actually yesterday was the deadline for it. In September is the prestigious Council for the Advancement of Nursing Science in Washington, D.C., and sort of like the creme de creme of nursing research is there. So anyhow, yesterday was the deadline for our abstract to get in. And it was interesting that part of what we're looking at in this group, we're looking at American-born women, immigrant women with documents, and immigrant women without documents. And the marginality index, I mean, American women had the lowest marginality. The women with immigrants with documentation had more, but the one with the highest was the immigration with no documents. And the truth of that is exactly what you said. They're silenced because they're so fearful of being deported back. So, I mean, it's really one of the ways their perpetrators leverage is through that silence.
Is there any indication it's becoming, I think it'd be hard with the silence to know, but is there any indication that it's becoming more prevalent or less?
Well, of the silencing?
No, I'm sorry.
Of the abuse,
If you
the
have
violence?
abuse and violence. Do
Oh,
we have any idea?
Oh, I think they're saying it's escalating.
Escalated.
Stop and look how often you're seeing
Yeah.
women killed. You know, this fellow who blew up his home with the 2 children in it.
Yeah.
The wife is missing. Where do you think that wife is? She's
Yeah.
dead somewhere.
Yeah, sure.
And we'll never be able to find her probably now.
Right.
But I mean, more than likely she was dead first, and now he's. And what happens so often? How many times have you seen, you know, this
Oh, yeah.
suicide suicide cycle that we see?
Or the
Has it
killing of
escalated?
pregnant
Yeah.
women.
Has it escalated, or are we just better at reporting it?
That's what
I
I'm
think it's
wondering.
escalated.
Well,
Because I don't see the escalation.
you don't see the escalation.
No, I just see that we're reporting it. We also have defined it more clearly. So,
Well-
so if you ask me, have you been abused? If my definition is different than yours, I might say no. But if you give me a definition, then
Oh,
I might
absolutely,
say yes.
absolutely. And that's part of it. The way I started with the CDC, they have actually identified a good working definition, and true when you define it. But you know, maybe it's been prevalent. I'm just amazed at the femicide study and what we've seen with women dying at the hands of their intimate partner. It's just amazing what we've seen. So.
So that statistic has increased. The number of women dying at the hands of
Yes.
intimate partners.
I was very struck by the handicapped women would be such a high percent, 60%.
But stop and think, a
Yeah.
disabled woman is so often dependent on their caretaker.
Yes.
And, you know, caretaker burden is quite high. It takes a lot to take care of a disabled person. The frustration that builds, you know, economic times, there's a lot of different mediating factors there. But anyhow, yeah, it is very prevalent in the disabled community.
A lot with disabled children, chronically disabled children, particularly when there's some sort of mental. I worked with chronically disabled, and we saw a lot.
Yeah.
Because they're the lowest on the pecking order.
Well, they're
And
the
they
most
won't-
vulnerable.
the
Stop
most-
and
yeah.
think of the vulnerability. Okay, they really can't defend themselves that well. But I know we think, oh, you know, in our heart we want to be benevolent to these people. Okay, but it's the reality. It's the reality is really that abuse is very common in that population.
You know, I think as fathers often feel concerned about their daughter that's the most beautiful daughter, and not necessarily for those that, you know, they think that men are going to really take advantage of this beauty, you know, want her and take advantage of her. Is there any, I mean, this is mental thought, men's thought. Is there any indication that the beauty of the person makes them, or if they're wearing, you know, men think if they wear skimpy clothes, revealing clothes, that the woman must want it.
Oh, that she's asking for.
Yeah.
That's the big thing. Oh, she's
Right,
asking
she's
for it.
asking for it.
I'm afraid I don't have that research to support.
Yeah, I wonder psychologically, because I really,
That is
I
interesting.
really
That's
think,
interesting. I hadn't thought about the beauty aspect of it.
yeah.
But anyhow.
In marginalized populations, has the violence increased? Did you do that subset?
No. I mean, yeah, abuse is high. The higher the marginalization, the higher, and there's significant relationship there. Yes, there, you know, definitely. It is higher if you're marginalized.
I just wonder if it has, again, I wonder if the number of incidents have increased, or is it just that they're talking about it more?
Reported. Well, it's hard to say. Again, it's such a new science. You know, we really, the research is still in its infancy. But yes, we have much better. But I think society was more stable in many ways. You know, you had family practitioners who followed you. You had the family was cohesive for much support. I think the breakup of family has something to do with it. You know, we're more isolated now than we were 30 years ago. So I'm not sure I can answer that question. Yes, we definitely, you know, we have such good communication now. Everything's you know, within minutes of something happening, we're being informed. So yes, we have around the world in 80 seconds or something like that. Or, you know, it's amazing what you can find out what's going on. So.
Well, we really appreciate it. Thank you
Thank you.
so much.